surgery because there isn't anywhere to do the surgery. And when you can't do the surgery, the administrative work increases, exponentially, because you have to find patients, keep them somewhere, you have to cancel follow-ups, and it's become breast surgery is a fair bit of office-based work, so that's become even more challenging. So it's a challenging time, I think, for all, but
Well, I've got about 30 patients waiting for surgery.
Gosh.
And I've operated 2 out of the last 5 Saturdays all day. I operated all day on New Year's Eve. And I'm still getting some theatre time, but not half as much as I would usually have. And the whole thing is just going on, really. I must admit, last March, I thought it would all be finished for July and we'd be back to normal. That was quite naive, wasn't it?
Yeah, an anniversary.
And all of you have received, started your vaccinations?
Yes, at least one vaccine.
Yeah, I know.
One dose.
Enormous feeling of relief.
Yeah,
True.
that is true.
Because it's just that, it's just a question of time. I've got so many friends and colleagues who've stayed well until the last month, and then they caught the thing.
Yeah.
So, Vaishali, how are you going to run this program? Both of them are here.
So I will just introduce the webinar, today's webinar, and then I'll hand over to you to introduce Professor Baildam and Dr. Basu. And then later on, once the talks are over, then I will invite Dr. Goel to move on to panel discussion. And obviously, all 3 of you, including Dr. Shraddha, are going to be for the panel as well.
So who is going first, Naren or Prof?
I think it's
Naren.
Naren first.
Naren,
first, okay.
When it comes to the sort of panel discussion, what's the best thing to do? We mute ourselves and then come in, or
yes,
I think that is the best. Yeah.
So probably Dr. Goel will be addressing, individually.
Okay.
Yeah.
But if any time you have a comment to make, we would welcome that. Yeah.
Okay.
And moreover, there would be a lot of questions from the participant, from the audience in the chat box. So in between, if you find time, you could even answer, or maybe towards the end of the panel, we can take up those questions.
That's fine. Will this be available for people to see afterwards?
Yes.
Will it be on YouTube?
Yes, it will be.
In the YouTube,
Yeah. So we have a channel on YouTube wherein all the previous webinars are also available for watching.
Oh, nice.
Yeah.
Actually, I had put a link in this WhatsApp group also in the beginning for this YouTube channel. Yeah.
Lovely. I'll look up that. I just remember seeing the name YouTube. What are things like in India at the moment? Is it difficult, or are you managing with this?
Much better compared to what you guys are having at this moment. So the cases have come down. Even the ICU admissions are also much better. And the vaccination program has rolled in wonderfully well now. So all of us, we have got the first dose of vaccination recently.
Good.
So far, it's looking much better.
Good.
Actually, the burden has come down so much in recent times. Everybody is saying there may not be a second wave in India. I don't know.
Well, it would be wonderful.
Finger crossed, yeah.
That would be wonderful. We've just been absolutely battered by this.
True.
And we had it almost under control last August. There were so few deaths, and the whole line of numbers had flattened out. And then last part of August, September, schools went back. The whole thing's just taken off.
There was an article I read last week about why we're in the situation in the UK that we are in. We're an island, and if you compare ourselves, clearly it's not comparing apples with apples, but if you compare ourselves to other islands, New Zealand or whatever, they've managed to close down everything to reduce it. But I just I can't understand why we are where we are. I did an ITU night last week, and it was just, they were saying that in the first wave, the ITU was filled with patients from Black, Asian minorities. This time round, it's a much more mixed representation of the general population of Great Britain, but it's significant. It's a significant problem, and I just, it was one of the things Prof and I were talking about, which is, for all of us, we sort of, it's attention to detail, fine surgery, bespoke medicine, everything. It's almost like wartime now. Everything we're talking about, and risk-reducing surgery. It's, I don't know when we'll do another risk-reducing operation. Perhaps that's not something to go into too much detail today, but it's real. I don't know. Soon we'll get the patients who are waiting for their risk-reducing surgery presenting with their cancers. Has to be, if it hasn't already happened.
Yeah, I'm actually doing a BRCA2 in 2 weeks' time at the Christie, and essentially I've argued the case that BRCA2 patients are on the cancer pathway, because it's just a question of when they get it. It's not a question of aesthetic surgery.
Dr. Julka is also there. Good evening, sir. Welcome.
Is muted. So it's
time, I
2
think
minutes past 6. Yeah. So should I?
Good evening. Good evening.
Good evening, sir. Welcome. Yeah, Dr. Vaishali, please.
Yeah. Okay. So without wasting any further time, I would invite and welcome all the faculty members as well as the participants. Dr. Goyal and I have been, I am myself Dr. Vaishali Zamre. We have been actually organizing a series of webinars on some focused topics in breast cancer. And today happens to be the 13th in the series. In the last webinar, we have actually had a wonderful panel of experts in the field of molecular oncology who have taken us through the technical nitty-gritties of genetic testing when it comes to hereditary breast cancer. And today we are going to discuss the clinical challenges which as a clinician we face when we come across a patient who is likely to be harboring a genetic mutation. So at the outset, I would like to actually thank Dr. Shankaran Narayanan, who has been instrumental in organizing this webinar by inviting Dr. Andrew Baildam and Dr. Naren Basu and Dr. Shraddha Lakhani. And we have another wonderful array of panelists with us. So before wasting any further time, I would actually invite Dr. Shankaran Narayanan, who is an oncoplastic breast surgeon in the UK, in North Midlands, to introduce the speakers and get the ball rolling. Over to you, Dr. Shankar.
Thank you. Good afternoon and good evening in India. It's a great pleasure to invite both Dr. Naren Basu and Professor Baildam. First talk is going to be by Naren. He's going to talk about management issues in patients with hereditary breast cancer. Naren is well known in our circle. He is our contemporary. He graduated from Bartholomew's and did his rotation in London. Then he happened to work with Professor Baildam in Wythenshawe, and his thesis was in BRCA carriers, contralateral breast cancers, and he has written a lot about the contralateral mastectomy guidelines, and he's trying to set up genetic service at Birmingham. He's a wonderful speaker, very nice man to work with. He's going to talk about and open this talk. And I will introduce Professor Baildam before he talks. Thank you. I think we're going to do all the discussion at the end of both talks. That will be easier. Naren, floor is yours.
Right. Thank you very much, Shankar. And it's a real privilege to be talking to yourselves. I'm just going to share my screen so we can get the ball rolling. It's sorry, sorry, just bear with me 1 minute.
Yeah, you have to go back to the slide. Yeah.
What I was just about to say, it's almost snowing here, but it's not the type of snow that anyone cares. So hopefully you can all see that. Is that right?
Yes, we can see.
Yeah,
Yes.
you can see.
So as Shankar said, I'm one of the breast surgeons in Birmingham, and just sort of 30 seconds about myself, so you know why I'm here. The bottom picture is a picture, an overview of Birmingham. We're the second city in the UK. I'm an avid cricket fan, and I don't really need to go too much into that. And sort of my links with Professor Baildam are through Manchester, really. And I'm very humbled to be sort of linked with the Manchester team, who are giants in the field of breast cancer surgery and genetics. So I'm hoping to really take you through what I think is the pathway that we see with patients who end up having breast cancer, but they have some form of familial history. And what could those heritable factors be? So, even before they've come through the doors in terms of breast cancer, could we have predicted it perhaps? We then talk about the therapeutic options, and I'll concentrate mainly on the surgical options, clearly because I'm a surgeon, but we'll also try to talk about some of the guidelines regarding radiotherapy, chemotherapy, biological agents. And I'll not talk too much about anti-endocrine therapies. So essentially, where are we in 2021? Well, if we look at this initial publication, and I'd really suggest going back at some point and having a look at this, because this publication from 2013, it's a little bit old now, but it looked at critical research gaps and translational priorities within the treatment of breast cancer. And what we identified was in the heritable component of breast cancer. If you look at 2007, the top graph, we didn't know really what caused 68% of heritable breast cancer. Fast forward to 2013, and we've reduced that to about 50%. So we've identified, and we are continuing to identify at a reasonable pace, more and more about heritable breast cancer. But it's fair to say at the outset that there's still a lot that we don't know, and as time passes, we will gather more information. And I think genome-wide association studies has really helped us to unravel and unpick where we are, because I guess if you look at the pie chart, the proportion of BRCA1, BRCA2 hasn't changed. But what has changed is the identification of SNPs, and I'll come back to SNPs shortly. So essentially, I'm just going to also take you through what are the high penetrance genes that patients could have had before they presented to you in the clinic. And this is actually data taken out from a chapter that's coming out shortly in the Oxford Textbook of Surgery that Professor Evans and myself contributed to. So I guess the most well-knowns are the BRCA1s and the BRCA2s. And one of the things we've learned is talking about a range of risk rather than a particular risk. So the range of risk that we would quote, and it will vary according to which publications you look at, but if we look at the BRCA1s, it would be a 60 to sort of 85% lifetime risk. We would need to think about other cancers that may present along with that, so ovarian, pancreas, prostate, cervix. And when we look at the type of biology of the breast cancer, the vast majority, at least 3/4 of them, are the triple negative breast cancer type. And we'll go into that in a little bit more detail shortly. How common is it? What is the penetrance of this gene? Well, it's about 1 to 1 in 500 to 1 in 900. And it tends to be a frame shift mutation in the chromosome number 17. Let's compare that to BRCA2. The range is wider. It's between 40 to 85%. There is about 10% of male breast cancers, and we'd see in the UK about 400 breast cancers. So about 10% of them will have a BRCA2 mutation. There's also a lesser risk of ovarian cancer, cholangiocarcinoma, melanoma, pancreatic cancers. And the breast cancers tend to be more similar to the sporadic type of breast cancer we get. The penetrance is about 1 in 400 to 1 in 800, and there's a large founder effect in chromosome 13. We then move on to PALB2, a lesser risk associated also with ovarian, pancreatic, and male breast cancers. And we're actually starting to gather more information and data about the breast cancer pathology, but it's a relatively newer gene compared to the first two. The next one, I guess, is P53, the most commonly mutated gene in all cancers, and the breast cancer risk by 30 is about 50%, and about 90% of these patients will get breast cancer by 60. So it's extremely common and important. And what's really important, and I'd say that this is a take-home message, that if we do see under 30 in our practice, we should remember that there's probably a 5% chance that they harbor a pathogenic variant in the P53 mutation. And that's really important because if we subject them to radiotherapy, we can cause some iatrogenic cancers. The other things to remember are sarcomas, brain tumors, leukemias. There tends to be a high percentage of HER2 breast cancers, and the mutation is in chromosome 17, and it's known as the guardian of the genome. I'll quickly go through STAC11, CDH, and P10. It's the important cancers to be associated with CDH are diffuse gastric cancers, and just under half are lobulars. And with the P10 cohort, we tend to find a Cowden syndrome type. And one of the questions I was asked in Manchester is, how do you know a patient sitting in front of you with Cowden syndrome? I didn't have the answer, but the answer was you measure their hat size because they get macrocephaly. So what about breast cancer? We've missed a slide, so apologies. Yes, so hopefully you can all see that. I'm just going to take you through a very brief history about the BRCA gene mutation analysis, because I think it's important to understand where we are and how we got here. So in 1990, Mary King's group in the US discovered the BRCA1 gene, and then it was cloned by Myriad essentially in 1994. 4 years down the line in the UK, Worcester and group discovered the BRCA2 gene, and it was cloned by Myriad. And so then began almost 2-decade-long almost monopoly by Myriad in terms of gene testing. And it was only in 2013 where there was a court ruling which identified that the isolation of genes in nature do not render them patentable. So it's really since 2013 and beyond that we've now got a whole array of commercial genetic testing. So prior to that, it used to be Myriad, and since then, it's quite commercially available. So I think that's the sort of history part. We spoke in the earlier slide about the high penetrance genes. There are some moderate penetrance genes. We won't need to talk too much about them. ATM associated with ataxia telangiectasia, CHEK2, and there's the BRIP2 gene, which is refuted as a breast cancer gene by some experts. We also look, and we will be finding out more and more about these low penetrance genes, and we call them these single nucleotide polymorphisms. They're pretty common, and we think that on their own, there's a very minimal to modest increase in risk, 1.05 to 1.4 times. But put them together, and we have a pretty impressive multiplicative and polygenic relationship. And it's likely that in the future, actually, we might use SNPs to further identify risk in a little bit more of an important way. So I guess for the benefits of everyone listening in today, it's pretty important to figure out, before we get into the nitty-gritty, is breast cancer the same disease in the Indian subcontinent or in parts of Asia as it is in the UK? And I think you all know all of this, but in India, for example, there's about 160,000 new breast cancers a year compared to 55,000 in the UK. But more interestingly, about 90,000 deaths are identified. And of more interest, as you'll see very shortly, is the distribution of the disease. So in the UK, a rule of thumb is that 80% of breast cancers occur in women over the age of 50. It's very different in India, and I think it's really important to understand that before we talk about the surgical treatments. So this is a paper by Singh et al. Published in Breast Cancer Research Treatment in 2017, and they looked at just over 1,000 patients in India who'd had breast cancer and ovarian cancer. And when they looked at it and they did genetic testing, they used a panel of about 14 genes. Just over half were negative, about 15% were VUS, and just under a third came back as positive for a gene. And when we looked further into that, the majority, almost 2/3, was in the BRCA gene. And you might, and you know, the next slide should sort of identify why, perhaps because of the higher rate of triple negative breast cancers. But there were about a fifth of BRCA2 patients and about 7% of TP53 patients. So I think it's important to understand that in this cohort of patients, a third of them had a gene that was positive, and of that, 2/3 was the BRCA1 gene. So then we go to Thakur's publication in 2018, and we look at actually what is the proportion of breast cancers in India compared to UK that are triple negative breast cancer. And although it will vary, as the slide on the right shows, there is a variation from Nagpur. About 45% of breast cancers are meant to be triple negative breast cancer, compared to just under 25% in Hyderabad. But the take-home message is that just under a third of the breast cancers in India are triple negative breast cancers, compared to in the UK, where we think it's between 10 to 15%, although there are some important ranges. So moving on to, I guess, surgical management. So if we were to see a patient with a significant family history of breast cancer, we would test them and put them through the genetic testing, and they turned out to have a mutation in the BRCA1 gene, the BRCA2 gene, perhaps not, and definitely not the TP53 gene. Would they be better off with a lumpectomy, breast-conserving surgery, or a mastectomy? Well, let's take a look at the data. A meta-analysis of 18 studies shows that the overall survival, when you compare mastectomy in green versus breast-conserving surgery in red, is almost similar. So there isn't a significant survival benefit whether someone with a high penetrance gene other than the TP53 gene has a mastectomy or breast-conserving surgery. However, if you look at ipsilateral recurrence at 5 years, 10 years, and 15 years, it's almost a threefold difference between a recurrence when someone has breast-conserving surgery or someone has a mastectomy. And I think that's the important part that we need to take home, which is when we counsel our patients who have a genetic mutation between breast cancer, breast-conserving surgery, and a mastectomy, is to identify that there may not be a significant survival benefit between a lumpectomy or a mastectomy, but there's definitely a significant difference between local recurrence. And the graph there takes you through the pooled data. So the next part of the conversation in the surgical clinic, and in a lot of the meetings that we have, particularly in the UK and the US, one of the things that keeps coming up time and time again is the woman who is diagnosed with breast cancer, and she's sitting in your clinic and in your outpatient, and what she'll say to you is, actually, I've got a unilateral breast cancer. I would like to have both breast cancers removed, both breasts removed, sorry, apologies. And that's a very difficult conversation for us to have. And if we look at the trends over time, we can see that the number of women requesting a double mastectomy for what's a unilateral breast cancer is increasing over time. It's actually trebled over the last decade, and it's a trend that we see more in the US, probably less so in the UK, and I imagine, having looked at the sort of evidence base, I couldn't find many at all, or if any, publications from India about contralateral risk-reducing mastectomies, but it may be something, you know, that may come into your practices in the very near future. So when we're talking about these women, and you know, a significant number of them will actually have a significant family history, what will be the reasons that they request a contralateral risk-reducing mastectomy? A genetic mutation will be a significant one, so if they have or harbor a genetic mutation in any of the genes that we've already discussed. If they've got a family history, but they don't actually have an identifiable gene, if they're anxious or fearful of a second breast cancer, or about their long-term survival, they potentially want to avoid chemotherapy in the future, where reconstruction is available, they want symmetry for their reconstruction, there's some mistrust in surveillance, or they're offered a surgical reconstructive option like the TRAM or the DIEP free flap option that is offered only the once. So those will be the drivers for requesting a contralateral mastectomy. And what could be the risk reduction that we could see with chemo prevention or surgery? So for the BRCA group, the BRCA1 and the BRCA2 group, we would see a 50% reduction by use of tamoxifen. In non-carriers, there would be a similar 50% reduction, and significantly more with aromatase inhibitors. With chemotherapy, we're looking at 0.6% reduction in breast cancer in the opposite side. And with contralateral risk-reducing mastectomies, it's almost a 15% reduction of breast cancers compared to less than 1% in the non-mutation group. And what has this meant really for our practices throughout the, particularly in the US and the UK? Well, in 2013, you'll all be aware that Angelina Jolie shared with the world that she carried a BRCA1 mutation. And since then, there's been a significant interest, particularly in the UK, particularly in the US, and more so coming more recently in the UK. And what has the effect of this been in terms of risk-reducing mastectomy? So the three graphs on your left are amongst are showing high risk patients who have had breast cancer. And up until 2013, if you look at the top graph, the number of mastectomies that we were doing, contralateral mastectomies, was roughly stable at about 20%. With Angelina Jolie's news, this jumps up to 70%. And when we look at the age and the risk, the lifetime risk, we can see that even when we look and separate them out, there's been a significant change between pre-2013 and since the Angelina Jolie news. So what happens in the media will clearly affect what happens within our own practices. And this paper is due to be published next month. So is there anything useful that we can use in terms of that patient sitting in front of us who may have a genetic mutation, who may have a significant family history, who wants some objective guidance as to what the risk of developing a breast cancer on the opposite side is? Well, we need to understand the data first, and the sporadic breast cancer risk is about 0.5% per year. So for a woman who doesn't have a known genetic mutation, we'd say that, okay, you've been diagnosed with a breast cancer. The risk of developing a breast cancer on the other side is about 0.5% per year. For BRCA carriers, it's about 2 to 3%. So for argument's sake, we have a 40-year-old BRCA carrier sitting in front of us. She wants to know what her lifetime risk is. Well, if we look at the middle bit, the number of years of contralateral breast cancer in the UK, if we calculate that a woman will live till about the age of 80, if she's 40 at presentation, she's got about 40 years of contralateral breast cancer risk to live through. We multiply that by, if she's a gene carrier, by about 2% or 3%, and we then identify that she's got a significant risk of contralateral breast cancer. However, if they don't have a genetic mutation and they are a sporadic breast cancer, that risk would be half. So over 40 years, that would be a 20% lifetime risk. And we managed to identify how we can modify that risk. And the modified risk that we look at is if they've had an oophorectomy, family history, as I mentioned, the gene carriage, and the estrogen receptor status. So I think that algorithm may be useful in your clinical setting if you're faced with a woman who wants to know what the risk is for her opposite breast. It is worth pointing out that when we did this work and published them as the Manchester guidelines for contralateral mastectomy, that this isn't a validated tool. So use it by all means, but it's not validated and does require validation. And it may be that you might find the following steps useful. You know, if you're faced with a lady who wants a contralateral mastectomy, take a history, calculate their risk of contralateral breast cancer, offer them a cooling off period. They don't necessarily need to have a bilateral mastectomy as part of their therapeutic surgery at the same time. Involve your multidisciplinary team and pay particular attention to the patient consent process. So moving on to the actual non-surgical management of hereditary breast cancer. And I think this is a very useful guidance that the American Society of Clinical Oncology, the American Society of Radiation Oncology, and the surgical oncologists have come through. And I think you can get that from JCO 2020 and the references right at the bottom. But the take-home messages are, for radiotherapy, we should not be withholding radiotherapy because of a mutation status, except for TP53. So by that we mean, if a lady comes to your practice and she is deemed to be, or she's found to have a genetic mutation in any of the genes other than the P53 mutation, we shouldn't withhold radiotherapy. There is no evidence for increased toxicity from radiation in any of the carriers except P53 mutation. However, if we get a P53 mutation carrier, we should recommend a mastectomy over breast conserving surgery, and if possible, avoid radiotherapy. What are their recommendations on systemic therapy? Well, for platinum agents, they are recommended versus taxanes in advanced breast cancer for BRCA carriers. In the neoadjuvant and adjuvant setting, the data isn't there to support the routine addition of platinum to anthracycline and taxanes-based chemotherapy. There's also a lot of interest generated on PARP inhibitors, and they are preferred to non-platinum single-agent chemotherapy for advanced breast cancer in BRCA1 and 2 carriers. Currently, there's insufficient data to recommend PARP inhibitors in the early breast cancer setting or in moderate penetrance genes. So I think they are pretty clear guidance from the American group, and I think I'll draw your attention to some of the recommendations because I think they're quite useful. In terms of biological agents, there's been a lot of interest in that, and I think it's worth pausing about this, and I'm I'm not clearly, I don't have a lot of experience with this, and our medical oncologists will be the ones, but I think in high risk triple negative breast cancer, and if we look at the Indian subcontinent, that's almost a third, maybe even just under half your patients that you see. There is a high risk of early recurrence and high mortality. Compare that to the UK setting, and about 12 to 15% of breast cancers are in the triple negative breast cancer setting. 3% of all of the breast cancers overall are BRCA1 or 2 if we were to analyze them. And about up to a fifth of triple negative breast cancers will have a BRCA1 and 2 mutation. So what can we offer these patients now or in the future if they are identified as triple negative breast cancer? And I think this publication by Professor Schmidt at Barts, published at New England Journal, is shedding some light in the use of pembrolizumab and PDL testing, so it has to be PDL positive, and the use of neoadjuvant chemotherapy in the breast cancer setting for triple negative breast cancers. And they found an increased pathological complete response of about 2/3 compared to about half the patients. So I would suggest watching this space, and perhaps if you do have access to PDL testing and you do have appropriate patients who may benefit from the use of this in the triple negative breast cancer setting with high genetic risk, this may be something to consider in the future. So really, I think this is the sort of last or penultimate slide, I guess, and it's really thinking about what should we be, what is the direction of travel overall for genetic testing in individuals with breast cancer. So if we go to the American Society of Breast Surgery, they brought out some guidance in 2018, 2019, and they recommended genetic testing for all patients with breast cancer. Now, in the UK, we don't have the capacity to do that in the NHS, and we have brought in what we call mainstream genetic testing in the clinic, and we have a subgroup of patients determined by age of triple negative breast cancer, whether they have a male breast cancer or whether they've had bilateral breast cancer. And for those group of patients, we can offer them gene testing of the BRCA1, BRCA2, and the PALB2 gene. But the Americans have taken that to a step further, and they recommend gene testing for all patients who have breast cancer. And what may be some of the benefits of that? Well, there was an interesting paper by Manoj Ramchandran from Barts, actually, published in JAMA, which showed a significant cost-effective benefit of actually recommending gene testing for all patients with breast cancer. And they identified a significant saving to the economy by doing that and preventing a number of cancers down the line. So I guess in a nutshell, the management of hereditary breast cancer is multimodal. There's clearly some surgical options to consider. There's some new chemotherapy agents that are coming through and systemic therapies. And it's also about managing the patient's expectations during a time which is particularly difficult. I think that's my part of the discussion, and we can take on board any questions towards the end.
Thank you, Naren. That was an excellent presentation, very clear, crisp, and very, very good presentation. Moving on to the next speaker. He doesn't need any introduction. I think he's well known throughout the world. Professor Baildam started mainly in Manchester, then he moved to Baildam as a professor. Now he's working in London, in Edwards Hospital, and also in Christie's. He's one of the pioneers in the oncoplastic breast surgery, setting up oncoplastic breast fellowship, made almost maybe 200, 300 oncoplastic surgeons in UK. Now today, most of the breast surgeons, he was the one to start with oncoplastic surgery. And his experience in dealing with genetic mutation may be going to 30 years, because Vitinsha is one of the biggest center which is dealing with genetics. So he is authority in the field, in both in terms of genetics and also in terms of oncoplastic. Floor is yours, Prof. Thanks for giving your time. Can you unmute yourself, Prof? Yeah.
Right, how's that?
Yes.
Yes, well, I do apologize. I forgot to unmute. So I just want to say what an enormous privilege it is to be asked to speak. I'm delighted to be here. Thank you for that incredibly generous introduction. I must say that when I started training in surgery, I had no interest in doing breast cancer surgery, and yet doing an MD thesis for 2 years in the molecular biology of breast cancer completely flipped my approach and my academic line, and it came from that really in the very late 1980s. So I'm delighted to share this with you. Firstly, I'm just going to ask Sankaran, can everybody see my front slide page?
Yes,
Yeah,
we can see you and we can hear you very well.
Perfect. So I'm going to talk to you about the management issues in a gene carrier for hereditary breast cancer, not somebody who has a cancer, but somebody who has that high risk. And I'm going to start off by talking to you, no conflicts of interest, talking to you about understanding the historical context and provision of management for women at high risk of hereditary breast cancer, and then to explore the evolution of the surgical techniques and the outcomes associated with risk-reducing mastectomy, which we used to call prophylactic mastectomy. And this is our typical kind of family history. This is one of our families, which is an old slide now, but you can see there are 3 generations here, grandmother here, grandchildren here, and you can see where it says all of this treatment, all of these people have had breast cancers. And on this slide, there's very few who actually haven't had breast cancer. And the family history system is what to do with those women. Naren has covered this beautifully, so I won't go through that again, but just to say we're increasingly seeing the SNPs as being important. Now, the Family History Clinic in Manchester was set up in 1987 in a secondary care breast clinic. This was before I joined them in 1993. The genetics service was initiated in 1990, and it served the close city population of 1.8 million, but wider referrals from the Northwest comprising about 5 million. And the aim of the clinic was to explain risk, to initiate annual screening, to give diet and lifestyle advice, and then in the early 1990s, the introduction of the IBIS-1 chemo prevention trial with tamoxifen versus placebo. But it was only 1994 that genetic testing started in this. And in the same year, I started doing risk-reducing surgery, essentially at the request of the clinical geneticists. Every person who comes to the clinic had a questionnaire that they had to fill in, appropriate clinic appointments with the geneticists or the medical oncologists, and clinical breast examination by the specialist nurses, and radiologists doing annual screening with mammography and with also more lately with magnetic resonance imaging. But there was also psycho-oncology advice given with a dedicated consultant psychiatrist, initially Penny Hopwood. The quality of life was measured, the risk communication, the best way of communicating risk and appreciating risk was explored. Whether or not gene testing was going to be offered to individuals, and a fully informed discussion for women at high risk of breast cancer for risk-reducing surgery. And I would come in only at that point for these women selected at particularly high risk, and I would initially be the dedicated surgeon who would have the discussion with them in the clinic about exploration as to whether they wanted to go down the line of surgery. Now, there is a publication coming out on which you're going to see quite a lot of data now. This is the hard copy of it, and the reference will be there in a moment on your screens. But this is a 33-year history of the Manchester Family Breast Clinic, which has just been published online in Cancers in December, 6 weeks ago, and it will be published in the main journal later this year. It is an extraordinary amount of data, and the lead author is Tony Howell, medical oncologist, which many of you know, instrumental in setting up the Family History Clinic with Gareth Evans. And I'm going to take you through what we've got from the clinic in terms of how we manage these women. So 33-year-old period, 14,311 women referred in, over half from general practitioners, 15% from other breast departments and breast surgeons, 21% from the clinical genetist clinics, and then the rest from heterogeneous other sources. This is the age range, 16 to 81. That's quite interesting that you'd refer someone at high risk at 81. But the interquartile range, which is much more informative, is early 30s to mid 40s, which is exactly what you would expect. 11,878 were below the age of 50, and the annual referrals ranged between 300 and 700. This is the publication that is going to come out. And if you want to make a note of that, it's published online in December in Cancers, and it's going to come out later in hard copy later this year. Fantastic effort. And everybody's name here has made a major contribution to this study and this publication, but overwhelmingly, Tony Howell and Gareth Evans have been the two real steer people of this. This slide shows you the annual referrals to the clinic going back to the late 1980s. And you can see the first few years, just a trickle of patients coming through, and then coming up much more in the late 90s, and then kind of dropping back a little bit. But then, as Naren has shown us, a difference coming again from the Angelina Jolie effect. And it's really the early 90s here that we started testing for BRCA. Interestingly, and this is statistically significant, you can see that the BMI, the body mass index of people attending, has gone up, and it's steadied off in the last decade. This shows you a little bit closer that, and you can see also the guideline dates here. So these are the main publications that have happened over this period of time with guidelines. Initially, Gareth Evans, Diana Eccles, and then the NICE guidelines that came in for the management of women with a strong family history. These are the actual number of referrals coming in. So as I told you, over half were from GPs, 15% from surgeons, a fifth from genetics clinic. Now the PROCAST study is interesting, and that's a prevalence of cancers on screening, and then there's the numbers all put together. I won't go through all those with you because it's important data in the study, but I'll highlight the things that I think are important for this talk. We estimated lifetime risk initially in the clinic using the Klaus method plus lifestyle and hormonal factors, and then subsequently from the early 2000s, the Tyra-Cuzick model and Boadicea. We found that the Gale model underpredicted risk compared to the other models. And then we allocated a moderate risk, which was 17 to 29% lifetime risk, and that was 38% of women who attended. And then a high risk, women who had more than a 30% lifetime risk, and that was 44.6%, including 6.4% with a breast cancer related gene. So obviously the women who weren't in these moderate or high risk groups were at average risk, and they were not then followed up in the family history clinic. They were discharged back to their GPs or the local clinic. Of 4,168 women who had BRCA1 and 2 testing, 736 were found to be gene carriers, and that's 5% of the clinic cohort, which is perhaps surprisingly small. But testing was rationed. We didn't test everybody, and 17.6% of those tested had a BRCA1 or a BRCA2. We also picked up these 11 ATMs, 11 CHEK2, and 7 PAL2s. In terms of radiological screening, I said to you that we did annual screening with mammography and with MRI. We didn't do both together, we alternated them. MRI came in, of course, much later in the series, but almost 130,000 women years of follow-up. 646 breast cancers occurred prospectively in this group, which was an annual incidence of 5 per 1,000, which is nearly, it's over 1.7 times the incidence picked up in the UK NHS breast screening programme, which of course is not driven by risk. Of those 646 breast cancers that occurred, 73% of them were node negative, which I think tells you a lot about close-knitted surveillance. 73% were relatively small at less than 20 millimeters. But in the BRCA1 and the BRCA2 women who developed cancers, 75% of them were less than 20, and then BRCA2, 85% were less than 20, reflecting the later benefit of MRI, and 61% was stage 1. And the breast cancer specific survival at 10 years was 91.3%, which compares to 76% of the overall current survival in England of the general breast cancer population. Chemo prevention trials, and Naren has told us a lot of really good data on that, but we found a really tiny number of women accepted. The number offered was far greater than the number who accepted, and overall only 5% of women accepted to go into a chemo prevention trial. We used to call risk-reducing mastectomy prophylactic mastectomy. We know that 30% of breast cancers in women less than 30 years with cancers are from these genes. We know the individual risk. Again, Naren has shown us that BRCA2 has only got a slightly lower risk than BRCA1. But some women are not gene carriers, but we can still calculate their risk of 25% or more. And our policy from the 90s was to offer these women a discussion about risk-reducing mastectomy and give them that choice. 5 to 6% of male breast cancer is apparently related to the BRCAs, and obviously, you know, the 10 to 40% of ovarian cancer as well. So a lot of our patients who have risk-reducing surgery do choose to have risk-reducing salpingo oophorectomy as well. In the late 90s, when I operated on probably no more than 30 or 35 patients, it hit the media. And this was the Sunday Times in 1997. If your family is susceptible to breast cancer, is a mastectomy a wise precaution? Asked Patsy Westcott. And I think you can tell from the title that Patsy Westcott's view was that it was not a sensible precaution. In fact, it was something that was unethical and shouldn't be done. This was taken up with the surgical community. Ian Fentiman, who was professor of surgery at Guy's, wrote an editorial in the BMJ in 1998, Prophylactic Mastectomy, Deliverance or Delusion. And he wrote, "It's a barbaric procedure which seldom, if ever, should be performed." I thought my career was almost ended before it had really much started. And we used to present data at these organizations, but I was always asked the same question: how can you justify mastectomies for women with normal breasts? And I'd said, they're not normal. They've got gene mutations in the cells, every single one of them. And just because you can't see it doesn't mean it's normal. We offered women nipple conservation, and we thought there was no proof not to offer that. So the question I was asked, why have you kept the nipples? What if they get recurrence? And my reply was, well, recurrence of what? They haven't actually had the breast cancer at this point. And other surgeons, particularly, incredulity, anger, and the media overall was really quite negative. So the women were pioneers. They were highly motivated. They were the ones who came and persuaded us to go and do it. But even in 2021, if you do this surgery, you will occasionally run into quite stiff opposition. What were the objectives of surgery? We didn't just sit down and think, let's give this a go. So we wrote the objectives: reduction in breast cancer incidence, and then much longer term breast cancer mortality, but also relief of anxiety. But it was important that we did not produce outcomes for these high-risk women that made them look mutilated. And so we had to bring in, right from the start, all the reconstructive and aesthetic options which they were offered in order that they could live as normal a life as possible. It's life-changing surgery. We want to reduce breast cancer. Secondarily, we want to diminish early breast cancer death, but we've got to achieve a high quality of life. We've got to have very high quality surgery with low complications. And I think most of us would agree that for decades of surgery leading up to the 90s saw very little improvements historically in breast cancer surgery anywhere. There were basically two operations, a wide lumpectomy or a mastectomy. And then in the 90s, that all changed. I was delighted to be one of the people who helped it to change. I had a great privilege of going off and learning and getting trained in plastics and reconstructive breast surgery in the early 90s, which at the time was quite radical, but the rest, as they say, is history. We also need to reduce the amount of revision surgery, but be very mindful of the psychological outcomes. And these were the possible pitfalls. Obviously, failure of the objectives, but doing it on the wrong patient, doing the wrong operation, unrealistic expectations, morbidity and litigation. And family history. We found some attendees of the clinic were not being honest about their family history. Why? The family history was fictitious. Munchausen's, what's the explanation for that? And so because of all these, we published in 2000 a protocol for preventative mastectomy with a paper which I think is still worth looking at, even though it's 21 years ago. It's still worth looking at as a protocol, as a guideline that you can use for offering risk-reducing mastectomy. And a minimum risk we took of 1 in 4 or 25% lifetime risk with a multidisciplinary team and with these important specialties with a minimum of 6 months discussion about the surgery. That's after you discovered their high risk and you've offered them the surgery. And these were the contraindications to surgery. We couldn't verify the risk. The family history was untrue. A current psychiatric disorder, which was against them making that choice, whether the decision was not the woman's herself, whether they had unrealistic expectations, whether there was a genetic test about to be delivered, or whether they had invalid reasons. So somebody saying, well, I've never liked my breasts and I want some implants is not a good reason for having a mastectomy. What about the surgeon? Well, really, you need to do this. You have to be understanding, which means being a doctor, and you also have to understand the science. But you've got to be trained in reconstructive surgery and a sculptor. I love that bit. What do you do? I'm a sculptor. But also, I think empathy is important. You have to be a team player to work with this complex system of people, and you've got to be much more than a technician or a surgical mechanic. And what about the consent? Well, we always talk to patients about, if you have the operation, what the possible complications can be, what to expect, but you've also got to talk to them about what happens if you do not have the operation. What is going to happen in terms of your trajectory? So what exactly is the operation? Well, there's never been a formal definition of risk-reducing surgery. And many operations are judged by the outcome, not by how they are technically performed. And there was no standard operation. We needed to remove all at-risk tissue. What about the extent of mastectomy? There were all these on offer. And of course, no single risk-reducing operation will suit all of these people. So you have to mix and match and do bespoke surgery for your individual in front of you. Any one of these could have a BRCA1 or a BRCA2 or a high-risk calculation. But the approach that you have to take to do a risk-reducing operation for this woman would be very different from the approach that you would take for this woman. And I think the reasons for that are visually obvious. But a detailed assessment of your patient is very important. Do the measurements, take photographs, write these in the notes. Patrick Manucci did a bit of a study in 2012 as to what was the concept of the aesthetic ideal breast. Everybody has their own opinion, but you have to work towards something. And this is one of my patients with a risk-reducing mastectomy. We've achieved what Patrick Manucci said was ideal, 45% of the volume of to remove the breast area, which is important for the possible sites of breast cancer, and that means including the axillary tail. Initially, we used a horizontal incision with a ptosis correction if we needed it. Later, we used Wise pattern or circumareolar skin-sparing mastectomy. So this was our initial incision if we were preserving the nipple. This is one of my early patients who is now 24 years after surgery. There she is now, and you can see the scars still there and there. And like many of these women, she's now the oldest woman in several generations who is alive and well without having developed or succumbed to breast cancer. This is before we changed her implants, which was the last picture that you saw. But the Wise pattern is also useful, both if you are removing the nipple, but if you're preserving the nipple, you can use it. This is a Wise pattern, a woman with a lot of ptosis, grade 3 breast ptosis, Wise pattern mastectomies with expanders, implants, nipple reconstructions, and then tattoos. Every operation is bespoke, individually tailored. You can preserve the nipple on a pedicle with a Wise pattern. Closed like that, like a reduction. You can do a vertical scar, and it all depends on the ptosis and the volume and the shape of the breast. You can do a tennis racket type of scar. You can remove the nipple with a straight incision and then do an implant after that. You can do a nipple reconstruction over the scar. And this is a woman with tissue expanders. You can see I've just expanded this one with immediate nipple reconstructions using the areola. So these are nipple reconstructions. They are not her original nipples, which were somewhere here. We can preserve the nipple using a circumareolar incision, provided we use a supraomedial pedicle here. And that's a kind of patient with tissue expanders and then permanent implants, same patient. Can we keep the nipple? Is it safe? Can we do it? Should we do it? And what are the pitfalls? Well, we have to go to the paradox. And the paradox is that in women who actually have breast cancer surgery and adjuvant therapy, we are retreating on the amount of surgery that they're given in terms of their multimodal treatment. But we're offering this radical surgery for women who are at high risk but haven't had it. Breast cancer's new frontier. What if I decide just to do nothing? So this is a patient that you've seen, risk-reducing surgery, reconstruction, and nipple areola reconstruction using an asymmetric trilobe flap followed by a tattoo. There you can see it. And this is a similar patient in which we've preserved the nipples. These are her original nipples. And there's the difference. Aesthetically, they're close. This is the reconstruction. This is another reconstruction. These are preserved. Is it safe to keep that? This is a woman who had bilateral mastectomies and reconstructions. She actually had LDs with Becker 35s, and she decided that never was she going to have nipple reconstruction. So it has to be your individual patient choice. But to look as to whether it's safe, we've got to look back at Carlson's original skin-sparing mastectomies, which he described a long time ago. We would now regard this as a skin-reducing mastectomy. We don't tend to do them with biopsy scars very much these days because we do have needle biopsies preoperatively. But we certainly now do a lot of these type of mastectomies where we do an incision through the circumareola. But what about, I suggest, a type 6, nipple sparing? We leave it on a pedicle, we take out the breast tissue and then put the nipple back in place. But we've got to look into what's published about whether preserving the nipple is safe. And there's a big problem with virtually all the publications which have been put out there regarding nipple preservation. And the big problem is that, like this one, which was one of the early ones, they've put together in one publication both patients who have actually had invasive breast cancer as well as women who have not. And that has really confounded the information that is out there. And it's true of just about all of these publications. But if you look at the patients in the series that have had breast cancers, these are the publications, follow-up, fairly short, but nipple areola recurrences in women who've had cancers and who've had the nipples preserved remains incredibly low. Again, only 5% of actual cancers occur under the nipple areola area. But you have to consider the nipple areola perfusion. And if you're dividing the area around the nipple and resuturing it, you've got to keep some kind of vascularity. And this is one of my patients. We've preserved the nipple. She's got an implant-based reconstruction. You can see the veins and the little arteries next to them still going into the preserved nipple. And you can see the scar line around the breast cone where we've done the mastectomy. And this is the kind of result you can get in a young woman with minimal ptosis who's had a single operation with the nipples preserved on deepithelialized bridges. There's the scar, and then an ADM with an implant. But you can't do that on a patient like this and keep the nipples, because you're going to have to keep a pedicle that long to keep the nipple alive. And in doing so, you are going to compromise the risk-reducing effectiveness of the operation. So I'm afraid that woman really cannot have her natural nipple preserved and yet still safely achieve risk-reducing surgery. That's the area you have to remove from within the breast itself. So you've got to be able to preserve the nipple, and the nipple itself, we know, has got very few terminal duct lobular units. This is Stollier. TDLs are scarce in the nipple, implications for nipple sparing mastectomy. Can the nipple be preserved? And then Yao, that's a review of the literature, worth looking at. But again, mixes up therapeutic mastectomy for cancer with patients not having cancer, but it is actually a very good paper and worth looking at. And this is Sia, who's went specifically for BRCA mutation carriers, but again, patients, some with surgery, look, 25%, some having prophylactic surgery only, 75%. Very confusing, and I still don't know why they did that. But you can free graft the nipple if you wish. Don't forget that. But that, of course, doesn't always work in quite the same way as proper nipple preservation, which often retains its sensation as well. What about psychosocial functioning? Does preservation of the nipple make a difference? This is Kelly Metcalf, and it does. Significantly better aesthetic perception, better image of body image and sexual functioning, but there's a similar decrease in cancer-related anxiety, whether they keep the nipple or not. They didn't look at nipple reconstruction, so we don't know if that would have assessed some of these issues. Can we keep the nipple? Yes, provided we can keep it alive and it doesn't necrose off and give us a massive problem of resurgery. If we can keep an aesthetic positioning and provide we do not leave significant breast tissue to support it. I'm going to take you now through our results. And in 2015, we did an analysis of which not just included our family history clinic, but it also included women referred in direct to myself from other centres who had not gone through our family history clinic. So the numbers are a little higher. And that I'll come back to the family history clinic numbers at the end. 460 age range there, 231 were mutation carriers, 6,500 women years of follow-up. If they had not had surgery, and we compared them with risk and age matched controls who had not had surgery, we would have expected 67 breast cancers, but we did actually observe only 3, which was a 95% reduction. The 3 developed, they were actually all BRCA carriers, and this just gives you a little bit of information. 2 have kept their nipples and 1 didn't. And of course, the 64 who avoided breast cancer also would have avoided all of this. Putatively, looking at Stephen Narod's data, 11 of them would have deceased. We updated these in 2017. At that point, 85 cancers were expected. We still only observed 3, and that data came from Gareth Evans. And then in our publication, we are only looking at the women who came through our own family history clinic. 451 chose risk-reducing mastectomy, and that was almost half of the BRCA1 and 2 carriers, but only 1 in 20 of the non-carriers who chose it. But if you looked at the banding of lifetime risk in a woman with a more than 40% calculated risk, 9.4% had surgery, 30 to 39%, 4.9%, and 25 to 29% lifetime risk, only 3% chose surgery. Of the 450 who did have risk-reducing surgery, 4 women developed breast cancer afterwards, all BRCA1 and 2, predicted 94 over almost 8,000 women years of follow-up. The risk reduction was 95.8%, and that's maintained. 20 of the women had no breast reconstruction, and they were mostly the earlier ones. 78% had breast reconstructions which were implant and expander based. 14% had autologous flaps, and 31% had nipple sparing. But if you take off the ones who had flaps, who mostly didn't have nipple sparing, and you take off the ones who had no reconstruction, then that puts the nipple sparing up to about 40%. And this planned surgical procedures, the average was 2.4, but that included the nipple reconstructions and it included removing tissue expanders and replacing them with permanent implants. Psychological outcomes, Penny Hopwood and colleagues published a comparison of 79 of these women who had surgery compared with 64 who declined. The ones who did have surgery had reduced psychological morbidity and reduced anxiety, but without a significant detrimental impact on their body image or sexual functioning. And of course, no talk on this is ever complete without a photograph of Angelina Jolie. We've seen a couple already. Naren, thank you for that. But after 2013, the number of operations being done in Manchester really went up a lot steeply. And suddenly it became almost a designer operation. So instead of being an operation which was considered unethical and brutal, we suddenly had women coming along, an increase in referrals to request the surgery. It's now at 1.7 times pre-Angelina Jolie. And we've got this, women asking for breast removal they don't need. So never has risk estimation and calculation been more important. So if you're going to do this, get a dedicated team together, clinic times and space, dedicated surgeons who know the whole thing from the genetics through to the plastics and reconstructive, put time in it and detail. All the patients are individuals and they're very different from patients who've already got diagnosed cancers. They're not willing to make some of those sacrifices that women with a diagnosed cancer are. Train people, pursue excellence, and continue care and support. And finally, a little article came out 18 months ago in which I basically did an overview of all the papers in the breast, current knowledge of risk-reducing mastectomy, indications, techniques, results, benefits, and harms. And I think that's a short little paper that's worth looking up because it's got all the references that you'll need. They're all there, which have been published on this over the years. Thank you very much for your attention. There is my email address if anybody wants to contact me, and I'm also on LinkedIn as well as Twitter. Thank you.
Thank you very much, Prof. I'm handing over to Arun to continue. It was an excellent presentation. A full view over the last 30 years experience, we can see that. Thank you. Arun?
Yeah. Thank you, Professor Baildam, and thank you, Dr. Shankar as well. I would request all three of you, Dr. Naren, Dr. Shankar, and Professor Baildam to stay on with us for the panel discussion as well. So after the brilliant talks we've just had, now we'll move on to panel discussion wherein all the clinical issues and concerns we face are going to be addressed. And the moderator for the session is Dr. Arun Goel, who is the Director of Surgical Oncology at Max Institute of Cancer Care, Max Hospital, Vaishali and Patparganj. And in addition to the speakers and Dr. Shankar, we are going to have Dr. SVS Dev, who is a professor and head of surgical oncology at All India Institute of Medical Sciences, Delhi, and National Cancer Institute, Jhajjar. Dr. Geeta Kadiaprath, who is the Director Surgical Oncology at Max Institute of Cancer Care, Max Hospital, Patparganj and Vaishali. We have Dr. Shona Nag, who is the Director Medical Oncology at Sahyadri Hospital, Pune. Dr. Raja Pramanik, who is Assistant Professor of Medical Oncology and at All India Institute of Medical Sciences, Delhi, and NCI, Jhajjar. We have Dr. Shraddha Lakhani, who is a consultant clinical psychologist at Walsall Healthcare NHS in Birmingham, and Dr. Amit Verma, who is a senior consultant molecular oncology at Max Hospital, Saket. So over to you, Dr. Goel.
Thank you, Dr. Vaishali. First of all, I must say that it's been a real pleasure and an honor to listen to the two speakers. Excellent talks which have really been illuminating. Thank you, Dr. Basu and Professor Baildam. And I welcome all the panelists. Basically, it is primarily an issue-based discussion where I will just give a very brief of a patient history to sort of get the ball rolling. But before we start that, I just want our Indian panelists to sort of give a bit of their experience in the field of hereditary breast cancer. And firstly, maybe we'll ask Dr. Shona. She's been in the field of breast oncology for a long time. Dr. Shona, what would be your comments about hereditary breast cancer, your experience in terms of how many cases do you see every year? What is patients' acceptance to testing and further?
So thanks for that, Dr. Goel, and thanks for having me aboard this evening. So basically, I joined Sahyadri as Director Oncology about 2.5 years ago. And at that time, we started a cancer genetics clinic. So breast cancer being my primary area of interest along with gynae cancers, we started running this clinic and we analyzed our data last year where we presented the preliminary results. So we had about 150 patients report to the genetic clinic over a period of 1.5 years. And of this 150, 80 underwent pre-test counseling and 55 opted for testing. And they were selected according to young triple negatives, patients with bilateral breast. I mean, the traditional, the criteria that we look at when we do genetic testing. And of these 55, we found 13 positives, all BRCA, and there were 10 BRCA1, 3 BRCA2, and 8 breast and 5 ovary. And we have done about 25 more tests after that. We're still waiting to update our data, but we found the uptake was much more in the younger patients. And they felt much more motivated to undergo testing, and perhaps level of awareness was better. Maybe they were more concerned about their outcomes. And yes, we have acted on these tests. We have a couple of patients who've metastasized who are on PARP inhibitors. We have done prophylactic surgeries. We have done BSOs for most of these breast cancer patients. So it has made a difference. And I have even used platinum upfront as single agent in the metastatic setting when they have relapsed. So it's made a difference to the way I manage my patients.
Thank you, Dr. Shona. And now I will move over to Dr. Dev and Dr. Raja Pramanik, who both represent Dr. B.R. Ambedkar Institute Rotary Cancer Hospital and the associated NCI judger also. Dr. Dev is a close friend, and I think from AIMS, we expect to hear the experience they have in the field of hereditary breast cancer in terms of testing and acceptance and sort of overall, just a brief summary. Dr. Dev,
thank you, Arun. Our interest in the genetics of breast cancer dates back to almost 2000 when we started just doing the BRCA testing. So our first publication from India was from AIMS. We published 2 papers with the basic technology. The genetic testing technology was different at that time. Then after that, what happened is the availability, a lot of changes have taken place in the genetic testing, NGS platforms, Sanger sequencing, a lot of things have happened. For 10 years, there was not much of activity. But again, in 2011 onwards, there was a resurgence in the interest with the availability of genetic testing in the private sector and other labs also. And then what we did is we just wanted to see the awareness, level of awareness, knowledge, and what is the attitude of Indian patients. So we did a prospective study of around 300 patients with a questionnaire-based study. And there was also an educational intervention which was involved. So we asked them the questionnaire regarding the knowledge and awareness of breast cancer, whether they are aware of genetic testing or they're aware of any risk reduction options. Then what we did, we gave a small educational intervention of around 10 minutes, describing all the basics. And we called them after 1 week to see the impact. Is there any change in the decision making? To our surprise, we found around the awareness levels, the study was done around 2-3 years back. The awareness levels were not very high, around 20 to 30% was the awareness regarding genetic testing and risk reductions. But after the educational intervention, it has made a major impact. The awareness and the decision-making ability is doubled after that. So that has actually encouraged us. Now we are almost mainstreaming The genetic counseling part, genetic screening part, Dr. Raja is also one of the active members. He will share his data. So now it is more or less a sort of a standard sort of assessments. We follow the NCCN criteria for screening of these patients. And coming to risk reductions, I think 2017, till 2017, I have been offering risk reducing surgery, but the uptake was almost zero till 2017. But in the last 2 years, we did around 30 patients of risk reduction of breast cancer plus ovarian cancer. So now the acceptance rates have gone up. Angelina effect is quite old, but I don't think, I think something has happened between 2017, the public awareness and all that. So now the acceptance levels are high, especially among young educated women. Now we have around 30 patients who had a risk reducing surgery. We do upfront reconstruction also, mostly implant based reconstructions. And who are suitable for ovarian, we are doing lap oophorectomies, risk reducing lap sulfing oophorectomies. Coming to the genetic data, I think Dr. Raja can just maybe briefly tell us the outcome of our genetic testing study. Dr. Raja, please.
Yeah, thank you, sir. So in the late 2017, I joined, sir, in this multidisciplinary team of hereditary breast ovarian cancers, and we regularly organized this tumor board concept. After starting this clinic, over the last 3 years, we had the experience. We have now an experience of around 305 patients. We have counseled 305 patients, and of both ovarian and breast cancers. Out of the 100 ovarian cancers we have counseled, 72 have opted for the test, and out of these, 40% of the patients have a mutation. Similar is the situation for breast cancers. What we follow is now mainstreaming. We follow the NCCN criteria. All our senior residents, both surgical oncology, medical and radiation oncology, they are trained. They identify the patient, counsel upfront, and ask for the testing. The difficult ones come to me. So for the pre-test counseling, and then I do the counseling and organize the testing. Once the report comes, post-test is done after the MDT, in which we surgeons, medical, radiation oncologists, all sit together and decide the plan of management. And then we do the post-test counseling. And then the senior surgeons counsel the patient for risk-reducing surgery multiple times after giving cooling off periods. And that's the uptake. But all these are all selected patients who qualify the NCCN criteria, and therefore this number of 40% is biased one. Even Dr. Naren showed the figures quoted by Dr. Jaya Singh et al. It was from the Strand Life Sciences 1,000 patient study from all over India. All these are selected patients who qualified the criteria for testing.
Correct.
So we wanted to know what is the actual incidence or actual prevalence of these mutations in our patient. This means we have to test all the incoming consecutive patients. We did this study. Dr. Deo was a part of this study, and last year just we have completed this study. 236 patients, consecutive patients, all comers, unselected, whether qualified the NCCN or not qualified. All of them underwent multi-gene panel testing, 104 gene panel testing, and if they were negative, reflex MLPA for large genomic rearrangements was also done. And this gives us a figure of 18.6%. So unselected North Indian population, we are having a mutation of 18.6%. This is very high as compared to similar data from US, which is 8.6% only. Similar data from Nigeria, where the triple negative is very high, is 11 to 13%. North Indians have 18.6%. And there seems to be a North Indian, South Indian divide. We do not have founder mutations. We do not have Ashkenazi Jewish mutations. So this is the latest study. We are in the process of publication. So 18.6% is our. And if we only follow the NCCN or MCG criteria, we are missing 11%. And we also saw that if we take this cutoff to 60, if we test all Indian patients up to 60, we can have a sensitivity of about 95%.
I think that's a very interesting bit of information. And in fact, that was one of the questions I was having in my mind, because in general, we say that in India, we have a higher percentage of younger breast cancer patients, and we have a higher percentage of triple negative patients, which was mentioned by Dr. Basu also. So it is I had that possibility in mind that we may be having a higher percentage of genetic or hereditary breast cancer. I think one of the possibilities may also be, let us say that in the West, Europe and USA, the environmental or lifestyle related breast cancer has increased so much that there may be a dilution in terms of the hereditary breast cancer component, which has not yet happened. Suppose if the lifestyle breast cancer were to double or triple, the percentage of hereditary breast cancer could come down. Is Dr. Amit Verma there? Dr. Amit?
Yes, sir. I'm listening, sir. Please.
Dr. Amit, you've been being a molecular oncologist, and so you have the primary task of counseling patients suspected to have hereditary cancer at MICC. Over last few years, what is your experience in terms of number of patients that you have counseled, and how many have accepted, and what has been the outcome of testing?
So over the years, sir, from across all the centers of Max Hospital, we have seen more than 800 plus cases, which are referred by our clinicians who are seeing breast cancer, whether it is surgeon or medical oncologist. But having said that, there are few cancer patients who come by themselves who have a known family history of breast cancer or other cancers for genetic counseling. So we get referrals in these certain patterns. And primarily it is by the surgical oncologist who refers the case when they have the initial diagnosis. So this is the trend. In terms of the acceptance for genetic counseling, most of the patients who are recently diagnosed with breast cancer, the acceptance for genetic counseling is very low. There are various reasons to it because they are looking for the treatment, not for the gene testing or genetic counseling at that point in time. However, once the treatment is over, they are in a peace of mind when they are worried about the future cancer risk and the next generation. They tend to go back to their physicians and talk about these aspects. And then the search comes for the genetic counseling. So these are the two challenges, what I just shared with you. In terms of the acceptance to the screening programs and the prophylactic programs, the uptake is very low. I don't see that many regular follow-ups by the patients who we counsel for the first time and followed by the for various reasons, which we can discuss later. But we see lack of motivation coming from the patients for regular follow-up for the cancer prevention, even if they're high risk.
Thank you, Dr. Amit. Dr. Shankar, say in UK, the service is offered, let's say, as part of the government provided care. So even there, do you find an issue of acceptance for genetic testing, or does everybody accept?
It varies, but again, this kind of genetic service is not available in every district general hospital, even teaching hospitals. So we send it to regional referral centers. And I think general awareness is there. Particularly, we get a very limited number of people around. So, but sometimes they lose family history in this our part. They don't know what happened to their sisters and brothers sometimes. So that problem is there. But it is a very organized service. So if they want the thing, definitely they get referred, and every individuals are getting referred, and all the high risk are identified, and they join a high risk screening program also, so they don't get lost. There is a system to capture everybody, and the general practitioners are well aware of that. And our colleagues in oncology and also in gynecology, they also send referrals back to the breast surgeons and get the genetic testing done. And I think that under the auspices of Naren and others, there is something called a Project Generate, which goes on. Anybody who is diagnosed with breast cancer, triple negative below 60, they get their genetic testing done, and results are given within 30 days, even before they start the treatment. Most of them will go for neoadjuvant with triple negative. So that was really organized service now. But still, it's individual perception regarding what they want to do. And the other problem here is insurance and the other things. They get really worried about what they want to do. And Prof will have more experience on this acceptance thing.
Yeah, thank you.
Prof?
I would basically take this particular initial case history, and This is a 49 years lady I saw recently, lump in left breast for 5 months, progressive, no other significant local or systemic symptoms. Clinically, she had a 7 by 6 centimeter lump. Maybe we can blame the corona pandemic for this, because of which she probably delayed seeking attention. She clinically, I would say it was strongly suspicious of malignancy, and she had this family history in mother, CA breast at the age of 55, but other pathological details not available. Maternal aunt had some head and neck malignancy. Again, she could not tell me the details, and maternal grandmother had hematological malignancy. The details not very clear. Dr. Geeta, is Dr. Dr.
Yeah,
Geeta, can you?
Yeah.
So if you have this sort of a history, would you be like, this is not a classical family history of a breast ovarian as such, but would you be thinking of hereditary cancer in such a case?
So she's, her family history in terms of, you would think a high risk of breast cancer is not very convincing, because the mother had it at 55, a postmenopausal breast cancer possibly. So head and neck malignancy and hematological malignancy, you would not really relate to, a breast cancer family history, really. It's not possibly contributing. But when you have multiple cancers, that itself is also a ground for looking for genetic mutations. So multiple cancers on the same side of the family would make you think that, because she's the fourth cancer now.
Yes.
And it's the third generation. So I think, one needs to look at it.
Dr. Amit, what do you say about this? Does she merit a thought along those lines?
Yes, so definitely the patient should be offered genetic counseling, not necessarily gene testing. And the rationale, what we can justify here is that the patient is less than 50 years of age, with the maternal side having a couple of cancers. In terms of the differential diagnosis, we can see that the patient, the biopsy is not yet done, so we are not very sure whether the lump is truly invasive cancer. But assuming if it is invasive cancer, so we can have the differential diagnosis of Leaf Romani at this juncture because of the hematological malignancy, what we can see in the grandmother. So that differential puts us to investigate accordingly, but definitely genetic counseling is a must.
Thank you. So this patient has undergone biopsy and FNAC from axilla. The biopsy is a grade 3 invasive breast cancer, NOS, no DCIS, no LY, tills 10 to 20%. ER negative, PR negative, HER2 negative, KI 67, 45%. So triple negative breast cancer. So Dr. Geeta, now?
She qualifies automatically for a
automatically she does qualify. Okay. Now, since Dr. Shona has to leave a bit early, so I would take some of the questions related to her domain. So we are talking to this patient about hereditary testing, and all discussion has been started. But in the meanwhile, she is clinically T3 N0 as far as the axillary FNAC is concerned. And we have asked her to start neoadjuvant chemotherapy while other discussions are going on. So Dr. Shona, in such a patient, young patient, triple negative, and let us say that genetic hereditary testing would be done, results may be available sometimes down the line. What would be your choice of neoadjuvant therapy now? And do you think it can be subject to change once the results of genetic testing are available?
Well, I don't really let the BRCA dictate my use of platinum in addition to the taxane while I'm giving neoadjuvant. I usually would start off with weekly paclitaxel in this patient. And if I really want a fast response, if it was fungating, if there was skin involvement, or if after 1 or 2 doses of taxane, I don't find a satisfactory response, that's when I come in with the platinum. So I don't use platinum for every patient, even if they are BRCA positive, because we know that they're exquisitely sensitive to alkylating agents as well, which we will be giving when we give the AC component. And although the PCR rates are more, it doesn't necessarily translate into an improved outcome in terms of PFS and OS. And we've got sufficient data to prove that. But yeah, if I found I wasn't getting a quick enough response, that's when I add platinum. So I do platinum, taxane first, plus or minus platinum, followed by AC, finish all the neoadjuvant chemotherapy. By the time the results have come, the only issue is that you are anyway here, if she's BRCA positive, possibly going to offer her a mastectomy and maybe even talk about contralateral surgery. So I would have to talk to my surgeon about what was being planned.
So the reason for giving taxanes first is that you could integrate platinums later on if required?
Correct.
Okay.
Correct.
Okay. Dr. Raja, yeah, sure, please.
No, and the sequence doesn't matter really. So if you look at the way MD Anderson functions, they do the taxane first in AC. And this last year, there was a very provocative paper on the sequencing of taxane and ANTRA, and they found that there was actually a difference in DFS when you started off with taxane. So this is a lesser known study, but we covered it in year in review this year. So it was quite interesting. But when I have, like, for example, if I'm waiting for a fish for a HER2, I will start with the taxane and then add it on at some point.
Okay.
If it's positive.
Dr. Raja, so you have this patient. What would be your choice of neoadjuvant therapy? Whether you would like to add platinum straight away or no?
No, sir. Our practice is to give EEC followed by the taxanes. BRCA status does not matter in our neoadjuvant chemotherapy regimen.
Okay. And maybe I can ask this question. Dr. Basu also mentioned about the keynote trial and the benefit of pembrolizumab. So, Dr. Shona, do you subscribe to the chasing the PCR?
Well, if it's I do believe that PCR is important for the triple negative and the HER2 positive subset. And I do know that my patients who get an RCB 0 or 1 are better prognosticated and they do much better. So it's very reassuring. Today, we are in an era of risk adapted therapy. So if there is residual disease, you can possibly target that with additional capecitabine for triple negative or with the Catherine-like approach in the HER2 positive. So yeah, I think PCR in these subsets is important.
I have in our setup, the medical oncologists have had a bit of a reluctance to use capecitabine as a risk adapted strategy. They say the tolerance has been poor. What is your experience with that?
So if you look at the doses, and I don't blame them, the doses in the CREATE-X are similar to what we use in colon cancer, 1250 per meter squared BD, 14 days on and 7 days off. Sometimes that does become difficult and you are forced to come down to a gram per meter squared. But 1 gram per meter squared is reasonably well tolerated. And I've been able to do that in almost 80% of my patients.
Dr. Raja, your opinion about pembrolizumab and capecitabine as a risk-adapted strategy?
So definitely, pembrolizumab I have not used. The data has recently come up, but I do not have any experience on that. Patients less than 1% would afford for that. And capecitabine is definitely risk-adapted. Capecitabine for residual disease is our practice, and 1 gram per meter squared. I definitely agree with Professor Dr. Shona that this is tolerable. This is well tolerated. We can give.
Okay. There was one question about chemo prevention and its benefit in triple negative breast cancer. It was in the chat box. So, Dr. Shona, like the general experience has been that when you give chemo prevention as an endocrine therapy, it is only the HR positive breast cancers that are prevented. So, in a patient who's say BRCA1 mutation carrier, does say tamoxifen or AIs have a benefit in terms of prevention?
Well, the data is there for that, but I must say I haven't used it. And see, you are doing a BSO, which is ovarian ablation anyway. all right? And that is benefiting the breast cancer risk. So similarly, tamoxifen, there are studies for chemoprevention. And when you look at the P1 study, a very small percentage, I think, were actually BRCA positive. So we weren't able to get much info, but there were studies after that that did show that these patients do benefit, but I haven't had the chance of using tamoxifen.
If I can play the devil's advocate, the data on BSO says a 50% reduction in breast cancer risk.
Correct.
Data on tamoxifen and AI says a 50% reduction in breast cancer risk. And this is pooled data, not an individual patient. So I could say that the benefit is similar whether you give tamoxifen, AI, or BSO. And it might probably be that they are all affecting the HR positive breast cancers.
Sure. Well, I think the cancers that were prevented were the HR positive breast cancers. I don't think they were very helpful in preventing the triple negatives or the ER negative cancers. So I don't know, I still do a BSO. I would like to know what the panel thinks.
Dr. Geeta, you want to add something?
I just wanted to add to the P1 trial. If you see the trial, there are a lot of proliferative lesions, which could be an ADH or a DCIS or just, sclerosing adenosis. They have recommended tamoxifen for those patients also and said there is an 80% risk reduction of risk of, getting breast cancer. So I think, in that, if you were to look at it in that sense, then even if you have a triple negative breast cancer on the contralateral side, it possibly does offer some sort of protection in the contralateral breast.
Okay, so I think Dr. Dev, you
yeah, basically, you see, this is just for the sake of surgical audience. This is for this patient, the surgical conversations which take place in the first 2 weeks are very, very important. Before you just mainstream for chemotherapy, because she has two sort of a very good options, surgical options, which are controversial. So suppose the genetic test comes positive, suppose it comes negative. So you have to start that conversation on the day of chemotherapy. Okay, and you also put a metal marker in the tumor bed, because if it is TNBC, if you're planning a BCS, if she is genetic testing negative, so that conversation has to start at this stage. Because by the week 4, you will have that kind of a clarity in the patient's mind.
Actually, I jumped over to the discussion because Dr. Shona had to sort of leave at 7:40. So now I'll come back to that discussion again. So, Dr. Shona, I would like to thank you. If you have time, I would request you to continue, but otherwise, it's been a pleasure having you.
Now. Thank you.
Yeah, sure.
Thank you very much, sir. Thank you.
So, Dr. Geeta, when do you like to start a discussion on genetic testing? Say, after the biopsy report comes, or when on day 1 you get a family history before the biopsy report? What is your practice?
So I think, there are various aspects to this, especially if it is a young patient who's not completed. So there are various aspects to it. If it is a 30-year-old who's just had one child or has not had any child at all. So, the fertility as well as the genetics happens at the same time, because, it is very, very important. And I think you need to start talking genetics right at the beginning, because it takes some time for the patient to imbibe this new concept, because they've been only thinking treatment and not thinking about anything else. So I think you have to initiate that dialogue right at the beginning. In fact, usually most of the time, Amit will vouch for it, because about 4 or 5 years ago, we were a little slack in getting onto this discussion, because I think there was probably less clarity on our part. And slowly we have also evolved with time. And now it is a constant that if you get breast cancer, you would definitely bring in the genetic bit earlier than later.
Okay. Dr. Dev, in IRCH, you have, say, dedicated genetic counseling facility, or is it the surgical and the clinical team which is handling this?
Yeah, I don't know. It's mostly done by the clinicians in IRCH. So because you see, a lot of these decision makers, the patient initial contact is with the clinicians, and most of the studies are being carried out by our residents. So we train them, and it is mostly the clinicians who are doing the counseling as of now.
Okay. I would like to call upon Dr. Shraddha Lakhani, who was a clinical psychologist. Dr. Shraddha, can you switch your video on and yeah. So
Hi.
now, basically, we would like to know, when do you think you need to come into the picture? Is it after the patient has been sort of seen by a genetic counselor, or when exactly do you want to come into the picture?
Absolutely. I would say it would have to be as soon as after they've seen the genetic counselor, so that they're aware of the risks.
Yes.
But I would say don't forget about what genetic counselling will do as well. So not everyone will take up the option of genetic counselling just because of the emotional impact, because then you've got guilt about having passed it on. You've got all sorts of emotional turmoil going on for women in terms of who they may have passed it on to. And, you know, all of this needs to be processed. So I would say absolutely straight after the genetic risks become available, but also to then, as a psychologist, to step in so that they understand what the risks mean. And that can be confirmed again, because often they'll come away with that thinking of, I know it's a gene, and becoming highly anxious. I just want it off. I just want it off. I want to get rid of all the cancer risk. But in that moment of making those decisions, they're almost making those decisions because there's such a big threat without really engaging the rational brain. So I would say, you know, like everyone's recommended, it's that cooling off period to say, let's have a think about it. Let's see what's best for you. But also just being aware that not everyone will take up that genetic counselling because of all of those worries.
So do you think a joint session with a genetic counselor and you, does it really help, or is it only that you should see sequentially?
We do it sequentially here because I don't class myself as a genetic counsellor. That happens elsewhere. By the time they've had that, then they're coming to me with some more questions, with some more concerns, but also the emotional impact of what they're thinking. Because it will sort of go through the whole family in terms of the gene testing, and that in itself, in terms of the ripple effect, somebody needs to pick that up. So our genetic counsellors will only see them once to decipher the genetic risk, but then it's the emotional processing that will be done potentially with myself.
And how often do you need to see them, or it depends upon the individual patient?
It does, but you know, I would say again, if you invest heavily in terms of that psychological support pre-surgery, and they've had all their questions answered, and often my role is to be that communicator between the consultant and the patient in layman's terms, in terms of understanding the risk. If you really invest in that and the patient is absolutely convinced in terms of what their understanding is, what their expectations are of the surgery, remembering that, and I know, you know, we've had fantastic talks and, you know, you're all experts, but there are still the risks of implants failing, of infections, all of this the patient needs to understand. And if you invest in all of that talk, then they don't need to see me much more after, because it helps with that adjustment.
Thank you. Yeah, Dr. Dev, please.
Yeah, just two quick points, Arun, because what our experience with Indian patients, when you do the counseling, we need to differentiate between the patients who are diagnosed with breast cancer, who are getting genetic testing done. The other is unaffected family members. The approach is different. You see, the most of the newly diagnosed breast cancer patients, the concern is about the cancer treatment and the outcomes. Start bombarding them with genetic issues in the first week or 2 weeks, it's very difficult for them to comprehend. So what we do is we do a slow incremental sort of a counseling. In the first visit, we only talk 10% of genetic, 90% of cancer management. So we give them time, we call them back after a week. Then we see how much they are keen for the genetic testing and counseling. The first interaction is to assess the patient's mindset, whether they're really interested, what is the family background. We just size up everything in the first visit. So then it is taken over the second week, third week. By the fourth week, they are in a good position. You will also know which patient is keen for genetic testing, which patient is keen for risk reduction. A lot of clarity will come by that. It is a process. I think it's a process.
And I think you make an interesting point, because these are the cultural differences as well.
Yes, absolutely.
They really are. And I understand that mindset, because again, thinking about genetic counseling and thinking about the divisions that can cause within families,
absolutely,
can be huge.
Absolutely.
Okay,
Dr. Arun,
yes, sir.
Just if I can,
yes.
Sure, sir. Please,
because one of my candidates had MD thesis on BRCA1 mutation in 100 consecutive breast cancer patients. That was way back in 2000, and we found about 16%, who were BRCA positive. So that was the data, and 2000 I'm talking, when I was in AIMS and I did that study. And that study was thesis of one of my patients. And now with Amit, I'm, Amit Verma, I'm for the last 5 years in Max, I'm doing constant counseling and genetic counseling. And we have done in almost all the cases below the age of 50, we are doing the germline mutations, and as well as who can afford, we are doing foundation 1. Now today only I found that RAD1 mutation was there in somatic, whereas germline there was no mutation.
Yes.
Now, so we have found different types of patients. So that is very interesting, germline is different, somatic is different. So that is where we consult Amit for all the
definitely.
features. Yes.
Thank you very much, sir. So, Dr. Geeta, we were discussing about the local treatment options. So, if a patient is going for genetic testing, so do you discuss the local treatment options before the results are available, or do you wait for the results to become available to discuss the local treatment options?
So it really depends upon, how she is going to be treated. Is it going to be surgery first, or is it going to be chemotherapy first?
Okay.
If it is going to be chemotherapy first, but you will have that discussion, just as Dr. Deo said, you have to talk to her about these options that are available, because there is no contraindication to doing a breast conservative surgery in a mutant. So you can just, park it on the side, tell her that it is possible. But if you were to have a new adjuvant chemotherapy, we can come back and have that discussion again with more conviction once you have the report of the genetic test. But if I were to operate her first and she's keen on a conservation, I'm not going to stop her from having that conservation. And then, by the time the genetics comes in, you can possibly be talking about radiation, whether you want radiation or not. If she goes to the genetics person, like she goes to Amit, and Amit tells her that you are a candidate for prophylactic or risk reducing mastectomies. At that point, she can consider having a risk reduction bilateral mastectomy before she goes in for radiation, because if she is going to not require radiation, say she's a node negative BRCA1 carrier, then why should she be subjected to radiation unnecessarily because she's had a conservation? She can consider mastectomy at that point. So the discussion will really veer around how the sequence happens, but you have to introduce that topic right in the beginning.
So if the patient is, say, operable, we could say 2.5 centimeter node negative cancer, and the patient is going for genetic testing, would you delay the local therapy till the results of genetic tests are available?
I would not delay it, and I'm sure the patient also would not want to delay just because she's waiting for, because the anxiety can be quite difficult. And I think we need to put this in perspective. See, the patient has come to you for treatment. So in the course of your discussion, you know that this is an important bit, but for her at that point of time, this is not important. It may be important to you, but for her, what is important is to deal with the disease as well. And I think it is our part of our duty also to reassure her that we will have this happening in parallel and not taking precedence over your treatment. So the treatment has to happen, I think, just as planned.
Dr. Dev, yeah. I would like your comments on this. You are muted.
Yeah, I agree with Dr. Geeta, absolutely. But maybe in a subset of patients who are with a very high risk of a probability of hereditary or familial, if the report is going to come in 3 weeks' time, sometimes if the patient wants, we counsel and wait for a while. Because recently we had two patients, a young doctor, she was operated. She was keen for genetic testing and risk reduction, but she had a surgery outside. And after that, the genetic test came as positive. So they already did a LICAP, a breast conservation. Then she came BRCA positive, keen for risk reduction. So we have to go back again, remove the LICAP, do a risk reduction surgery on bilaterally. Another patient, she had again a nurse. She was young, very likely to have mutation, but she was rushed with surgery. Then she came P53 positive. She had a breast conservation. And radiotherapy is contraindicated because P53. Again, we have to go back and operate. So I think I agree with Dr. Geeta, but in a small subset where there is the chances of mutation are high, sometimes I think the young surgeons nowadays should be a little careful before you jump for upfront surgery.
Right.
That's it.
And the paradox is also there are patients who do not merit a bilateral and they're after your life to get the other test off as well. So, you know, we are getting those patients also. And that it's a task to convince them more than the ones who are likely to be mutant carriers.
So, Dr. Shankar, in your setting also, if we have operable breast cancer, but genetic testing is being done, so what do you do? Do you delay the primary surgery and put the patient on some systemic therapy, or?
Majority of the triple negative cancers are about 2 centimeters. Mostly they're going to go for neoadjuvant chemotherapy if they're fit. So we have enough time to get the genetic testing done. So those who are operable, I think we will go ahead and do an operation with a clear mind that she might need bilateral mastectomy. So your incision, your thing, everything is planned very well. So, and we all, I think still Sharda there, Naren is there. They need a lot of counseling before you do a mastectomy in UKs for suddenly to a patient, particularly bilateral. So they need that cooling off period. So it's better to do the neoadjuvant chemotherapy, get everything under control. Then it gives a lot of time for the patient to think about it. And so we don't delay just because somebody who is conservable, we do a conservative surgery. The question comes before radiotherapy only, because they definitely need chemo if they're fit. And TP, as Naren quoted, the radiation contraindication very rare. So we don't hesitate doing a conservative surgery. What do you feel, Naren? Naren, what do? You think you may be seeing quite a lot of patients with conservable triple negatives?
No, I think you're right. We do pretty much the same. I think gene testing results take about 6 weeks. It's, you know, with the NGS now and the rapid movement, we can get results back a lot quicker. I think if they're very high risk, you know, under 30, it would be sensible to wait for a result. I think because clearly you don't want to do a radiation-induced problem. So I think that would be useful. But I guess sometimes for the under 30s, we might not get a genetic referral and a gene test done in a meaningful time. So as you said, it's a careful discussion that although we're trying to offer a treatment, there is a wider picture that we might not be aware of at the moment. And it takes careful consideration. So I think that part we do. The other part we were talking about, which was somatic and germline mutation, you know, a few years ago we did the 100,000 Genome Project, and we are identifying a number of somatic mutations and figuring out what that means. And we have found some obscure stuff, and we're trying to scratch our heads pretty hard to figure out what it all means. So it's an evolving situation, I guess.
One of the issues that I would like to bring here is, let's say in a patient who's been diagnosed as cancer, the contralateral mastectomy, the timing of contralateral mastectomy, should it be done along with the primary treatment, or should we wait for a reasonable period and see that there is no recurrence of disease, particularly in the setting of triple negative cancer? So I would like the opinion from Dr. Basu, Dr. Dev, Dr. Geeta, and Professor Andrew also. Dr. Basu?
So it's interesting because we might as well bring COVID into this because I think it is important. Currently in the UK, we would probably just do the therapeutic surgery because we don't really, in the NHS, have readily available, at least where we are, we don't have readily available access to non-cancer surgery. So we have a grading system. Cancer surgery is graded as category 2 surgery. It's likely that risk-reducing surgery, depending on the level of risk, is category 3. The reality of it now is that if we don't do the surgery at the same time, the lady will not have her subsequent surgery for 1, 2, 3 years now because of the backlog. So I think COVID is going to be a real problem. I don't know what the answer to that is. But, you know, some women, if they've had a family history, the moment they've been diagnosed with a breast cancer, they'd always thought about it. And provided they've had a reasonable amount of time within their cancer therapy, if they are, we think, ready for it, I don't think there's anything, if they're ready for it, they're counseled enough. We would sometimes do bilateral mastectomies, including a therapeutic mastectomy and a risk-reducing mastectomy at the same time, but we would go through that same process. I don't know what Prof. Baildam would use.
Prof.
Yeah, I agree with all of that. I think COVID has completely changed everything. And even last year, there was a period of, 4 months when the NHS recommendation was not to do any reconstruction at all, even with people who were having mastectomies for cancers. So there's a big backlog. My practice before all this did in point depend upon the individual. So I would always look at the stage of the primary cancer, and if the primary cancer is a very early stage, maybe they're not going to need chemotherapy or radiotherapy, small tumor, then if a woman is BRCA carrier or high risk family and wants bilateral surgery at the same time, I think that's very reasonable. And I do that. But I think if someone comes up with, node positive breast cancer, the important thing is that treatment of that reference cancer. And in that case, a woman may have delay of treatment if she's having contralateral surgery, which is risk reducing. Also, we all know you get that initial spike of recurrence within the first 3 years. So the first 3 years of a woman with a more locally advanced tumor stage-wise, the first 3 years is the important time. It's only after that 3 years that the contralateral breast becomes important. Yeah. So I would delay it in that situation, but I've got a lot of sympathy with the woman who's got an 8 millimeter grade 2 tumor, node negative, who's got a strong family history in BRCA. I'm very sympathetic to doing it all at once.
Sure. Wonderful. Dr. Dev, do you offer simultaneous?
Yeah, Dr. Arun, I fully agree with Dr. Baildam. First thing I look at is the disease burden. In locally advanced, her prognosis and survival is going to be determined by the index cancer, not by risk reduction. So in LABC, I don't push my patients for risk reduction at the same time. In early TNBCs, yes, I do offer them if they are motivated. And the other factor I also look at is the response to neoadjuvant chemotherapy. Because by the time you complete your neoadjuvant chemotherapy, you will know what kind of response. And the good responders who are likely to achieve a CR or a PATH CR, then I will be more motivated to offer the contralateral risk reduction.
And are you comfortable doing conservation in your practice with Dr. Basu showing that there is a higher risk of local recurrence, at least in these patients?
Yes, I think that is been shown in a lot of literature. Young patients, TNBCs, the long-term ipsilateral breast tumor recurrences are definitely higher. But if you see the current guidelines, it is not a contraindication.
Not a contraindication.
For breast conservation.
Yeah.
So we keep that option. We don't completely rule it out because of this, but we tell the patient that yes, there is a slight higher increased risk of ipsilateral breast tumor.
Dr. Geeta, you would have any difference of opinion or?
So I would agree, because see, if your 8 to 10% local recurrence rate is possibly matches with what would happen after a breast conservation in a neoadjuvant setting also. So I think, less than a 10%, we possibly are assuming that it is acceptable. But like I said, you have to have that discussion with the patient that it would.
And synchronous risk-reducing contralateral mastectomy, you do that?
So yes, we do that. It is, and a lot of times it is patient-driven also. So we could say that locally advanced breast cancer may not behave well in the future, but we have been disproved several times also, and especially from my conversations with Amit does say that BRCA1 mutation carriers with breast cancer tend to do better than your non-mutant carriers in a lot of ways. So if that is the case, then you should be offering simultaneous. I don't see any harm in offering a simultaneous contralateral risk reduction.
Can I ask Professor Andrew a question? Like in the bilateral risk reducing surgeries, have you found occult cancers in the breast?
Yeah, we did. We found 3.
Okay.
And then they're not risk reducing surgery then after that. They're actually therapeutic.
Yes.
So that detection happened after surgery or while preparing for surgery? After
surgery, because you see all of these women going for surgery have MR scans of the breasts, mammograms, ultrasounds. So yeah, if you detect the cancers, we pretty much get all of those out and then treat them therapeutically.
Yeah.
But we did have 3 who we discovered tumors in the pathology that we didn't expect. But they're excluded from the risk-reducing group because they're no longer risk-reducing.
I've had a patient who did not have a genetic testing. She had locally advanced breast cancer. She was an HR manager, and she said, look, I don't want to live with this other breast also, because she was kind of big breast. And she said, I want mastectomy of the other side also. And we did find DCIS in it, which was kind of very, very strange because no genetic testing.
Dr. Basu, would you recommend a sentinel lymph node biopsy when doing a contralateral prophylactic mastectomy or a bilateral risk-reducing surgery, provided with the possibility that there may be occult malignancy?
No. I think the data when we looked at it of occult, of the node being positive or being helpful at all for bilateral mastectomies in a healthy carrier, or a contralateral mastectomy was very minimal. Now it will depend a little bit on, I guess, the reconstructive options, and if it's particularly an autologous free flap option in our center, our plastic surgeons sometimes use the axilla. So they may be insistent on that, and I think that's a different conversation. For our bilateral mastectomies for healthy carriers who are having a bilateral DEP, we still don't do an upfront sentinel node. For a contralateral mastectomy, if they were having their therapeutic surgery, it would have to be a discussion as to, we sometimes do an upfront sentinel node on the therapeutic side. Is there a role for an upfront sentinel node on the contralateral side?
Okay.
Usually it's still no.
So, so recently I had the opportunity to look up this because, one of our patients with locally advanced breast cancer, so there was this conversation, should you be, because she was having a contralateral risk-reducing surgery as well, whether she should have a sentinel node biopsy. And when I looked up literature, the only subset which possibly benefits from a sentinel node biopsy is the one in which the index breast is a locally advanced breast cancer.
Okay.
Otherwise, no.
I think one more issue I would just like to raise, because there are a huge number of issues which could be discussed, and that issue is of VUS. Dr. Dev, since you have carried out a large number of testings, what is your experience with VUS
Dr. Arun, I think we have the exact percentage, Raja can tell, but we do have out of this NCCN qualifiers, 30 were positive, out of which 30 were pathogenic mutations, around 11% at VUS. So these 11%, mostly what we do is we just inform them, this is the kind of mutation, and just mostly keep them under close surveillance for these patients for the future sort of assessments. Dr. Raja, can you give the exact figure of our studies VUS?
Yes, sir. When we looked at all the consecutive patients, our VS rate was around 40%. Was 40%. And we in the post-test counseling, we explain to the patient that these are not actionable, but we follow the age-based, age-specific, and the family history-specific screening guidelines are followed in these patients. And we revisit the lab for any conversion, upgradation, or downgradation of these mutations every year, whether they have upgraded their pipelines or not. And the lab gives us the information. Till now, there have not been any upgradations or downgradations in the last 3 years or so.
Dr. Amit?
Yes, sir. I'm listening, sir.
Yeah, about VUS, what is your experience like? How often do you find VUS, and this revisiting the lab or a updation of the database? What is the system in private labs?
So, we have published our own data, and we have reported almost more than 24% of VUS, and we tend to see VUS more in BRCA2 gene as compared to BRCA1. For some certain database reasons, what the private laboratory share with us. So VUS percent is very high in coming from the Indian laboratory. In terms of the reclassifying the variant, few labs follow this thing very stringently, and they tend to revert back to us with the email information saying that yes, it has been reclassified as likely benign or likely pathogenic. But I have not come across many reclassification reports as of now. These are very handful reports in the, we can say, in the past 8 or 9 years of my practice at Max Hospital. We have hardly seen 5 reclassifications as of now. So we have done plenty of testing, gene testing for our patients. But having said that, only 5 reports come to me with the reclassification reflects that there is no stringent protocol followed by the private laboratories, and nor there is a way to challenge them as well, because it is very difficult for us to go back and do that again and again. So this is a true challenge for us.
Dr. Arun?
Yes.
It also depends on the lab which is doing, whether they have the long-term gene bank and clinical database. Like big players like Positive Biosciences. So they have got this kind of thing, but small-time laboratories, it's very difficult for them to expect reclassifications, especially.
So is there a need for maybe some national database of mutations in India with all private and government labs coming together?
Yeah, absolutely. I think Dr. Raja actually has proposed one project in the DBT. Dr. Raja, can you highlight the registry, breast cancer genetics registry?
Yes, sir. The variant calling is dependent on how good the lab is, how good the internal database of that lab is, because most of the database are borrowed from the West. So, and the Indian specific mutations are not there in the compendium. So, whichever lab has the best compendium of Indian specific mutations, they will classify them the best. So, the Professor Rajiv Sarin from Tata Memorial Hospital has proposed a Southeast Asian consortium of uploading these mutations into a common database.
Yes.
And actually, I wrote also a project similarly to maintain the registries. This is in the process. I think that will be an open access database to everyone for classification. Whatever we publish, for example, there have been publications from Rajiv Gandhi Institute, Dr. Anurag Mehta, etc. And the list of all these mutations is there in the literature, but we need to curate them into a proper registry, into proper libraries, so that the HGVS in the form of HGVS notations, so that they can be accessed by all the laboratories anywhere, public or private.
So I think we need more effort on opinion building in this direction, and maybe an element of advocacy also. And as I was saying that there's a huge amount that could be discussed, but we have already overshot a lot. So I would like to thank all the panelists here and hand over to Dr. Vaishali for closing the session.
Thank you.
Yeah, so once again, I would like to thank all the faculty members, especially Dr. Basu, Dr. Baildam, Dr. Shankar Narayanan, and all the Indian panelists as well. And I would also like to thank all the audience, all the participants for making this a very lively and interactive session. So we have learned a lot about the clinical management of these patients who are likely or who are having a genetic mutation. And let us hope that this information helps us in taking day-to-day decisions when we come across such patients, which we are going to see a lot in future as well. With this, I would like to thank all of you once again, and over to you, Dr. Goel, for your parting remarks.
No, I think Dr. Vaishali, that's enough. And once again, thanks everyone, and we'll be back with another session. Wait for the announcement. Thank you.
Thank you.
Thank you.
Thank you, Arun. Thank you, everyone.
Thanks, Dr. Dev, Dr. Raja, Dr. Geeta, Dr. Amit.
See you.
Thank you very much, sir.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye.
Bye. Thanks.